Welcome back to the Deep Dive. Today we are doing something a little different. We are rolling up our sleeves, scrubbing in, and putting on the white coats.
We are.
We're tackling a book that is basically legendary and maybe a little terrifying for anyone in med school. First Aid Cases for the USMLE Step 2 CK, second edition.
It is definitely a heavyweight title. And for anyone who doesn't know, that acronym, USMLE, it stands for the United States Medical Licensing Examination.
Okay.
And Step 2. That is the big hurdle where you stop just, memorizing biology facts and start actually thinking like a doctor.
Right, because Step 1 is all about the science. The
That-
mitochondria is the powerhouse of the cell, that kind of thing.
Exactly. But Step 2, and this book specifically, is about what happens when a real human being walks into your ER.
Which is why we're diving in.
Precisely. This book is a collection of 344 high-yield clinical cases, and the reason it's so valuable, even for listeners who aren't medical students, is because it teaches you how to think.
How to reason.
Yes. It's about clinical reasoning. It's the ultimate detective work.
I love that, the detective work of the human body. And the way this book teaches it is interesting, too. It uses something called active recall.
Ah, yes.
What does that actually mean in this context?
Well, most people study by just reading a textbook and highlighting things. That's passive.
Right. It feels like you're learning, but maybe you're not.
You're not retaining it. Active recall forces you to work. The book gives you a vignette, a short patient story, and then it just stops.
And you have to figure it out.
You have to commit to a diagnosis or a next step before you flip the page to see the answer.
It mimics the pressure of the exam room, right? You can't just look up the answer when a patient is staring at you.
Exactly. It builds that mental database.
So we have combed through these 344 cases, which are organized by specialty, and we've pulled out the most essential patterns.
We're going to try and crack these cases together.
Let's do it. Okay, so we have to start with the engine room, the heart and the lungs.
Cardiology and pulmonary?
Now, if I'm working in an ER, chest pain has to be the number one thing I'm worried about.
Oh, it's the absolute bread and butter of acute care.
Right.
But here's the challenge, Chest pain can be, well, it could be indigestion.
Or a pulled muscle.
Or it can be the heart attack that kills you in minutes. And your job is to distinguish the annoyance from the catastrophe.
So let's look at the big one first, the heart attack. Myocardial infarction. The book brings us up in a few cases, 3, 5, and 19. We all know the movie scene guy clutches his chest, falls over. Is that what we are looking for?
Sometimes. You're looking for that tight substernal pain, maybe radiating to the arm or jaw, sweating, what we call diaphoresis and shortness of breath.
Okay.
But the book breaks this down into a spectrum, which is really important. It's basically a plumbing problem.
A plumbing problem. Okay, stick with that analogy. How does it start?
It starts with stable angina. Imagine a pipe that's partially clogged with plaque. When you're just sitting there, enough blood gets through.
But if you exert yourself.
If you run for a bus, the heart needs more blood, the pipe can't deliver, and you get pain. You stop running.
The pain goes away.
Right. That's the warning light.
But when does it become a real emergency?
When the plumbing fails completely, that's unstable angina or a full-blown heart attack, the plaque in the artery actually ruptures.
And the body tries to fix it.
Yeah, the body tries to fix the rupture with a clot, but that clot ends up blocking the entire pipe.
And that's when the heart muscle starts to die.
Exactly. And medically, we distinguish this with an ECG. If the blockage is partial, you might get an STEMI, but if it's a total blockage, a DAM, you get the Hollywood heart attack, the STEMI.
And I'm guessing the ECG looks different there.
Oh, distinctly. Case 19 mentions ST segment elevation in leads V1 through V3. That tells you the anterior wall of the heart, the front of the pump, is dying right now.
Wow.
You'll also see what are called reciprocal depressions in other leads, which is like the electrical shadow of the injury.
And the book really emphasizes speed here. Time is muscle.
Time is absolutely muscle. You'll hear about monomorphine, oxygen, nitrates, aspirin. That's the anemia cocktail.
But that's not enough for a STEMI, right?
Not at all. For a STEMI, drugs aren't enough. You have to physically clear that blockage. That patient needs to go to the cath lab for a stent immediately.
How long do you have?
Ideally, 90 minutes.
Okay, now here's where it gets tricky. You have another patient with chest pain, but they say it feels like tearing, and it's going straight through to their back.
That is a massive red flag. That one word, tearing, is the clue.
This isn't a heart attack.
No. This is likely an aortic dissection. Case 4 covers this. The aorta, the main highway for blood out of the heart, its inner lining has torn apart.
Why does that distinction matter so much? Can't you just treat the pain?
If you treat a dissection like a heart attack, you might kill them.
Wow.
For a heart attack, we give blood thinners, right? Aspirin, heparin. If you give blood thinners to someone whose aorta is tearing open, they will bleed to death internally.
So pattern recognition is literally life or death there, tearing pain to the back.
Think dissection. Don't give aspirin yet. Lower their blood pressure and call a surgeon.
Okay, what about the silent killer? Case 1 describes an elderly guy, a smoker, who feels fine. But the doctor feels something weird on his stomach.
A pulsating mass near the umbilicus.
His belly button is pulsing.
That is an abdominal aortic aneurysm, a AAA. It's a ballooning of the aorta in the belly. And the scary part is, it's often asymptomatic until it pops.
So what's the takeaway?
The book's takeaway is that if you find a pulsating mass in a smoker over 60, you assume it's an aneurysm until you prove it's not. You have to screen for these.
Let's move up to the lungs. Pulmonary emergencies. Case 12, a trauma patient car crash, maybe a stabbing, gasping for air, neck veins popping out, and their windpipe is shifted.
That is a classic tension pneumothorax, and this is one of the few times in medicine where waiting for a test is the wrong answer.
Really? My first instinct is get a chest x-ray.
And that instinct would lose the patient. See, air is leaking into the chest cavity, but it can't get out. Pressure is building, crushing the lung, pushing the heart.
That's why the neck veins pop out.
Exactly. Blood can't get back to the heart. If you wait 20 minutes for an x-ray, the heart stops.
So what do?
You stick a needle in their chest. Immediately. You have to let the air out. The book is so clear about this. It is a clinical diagnosis. Trust your eyes and hands.
Got it. Let's shift to a pediatric case in the lungs. Case 7, the barking cough.
Croup. It sounds like a seal barking. It's caused by a virus.
And there's a specific visual sign for this one, right?
Yes, the steeple sign. If you x-ray the child's neck, the airway, which should be a wide column, it narrows to a sharp point.
Like the steeple of a church.
Exactly. It's from the swelling. It's frightening for parents, but we can usually manage it with steroids.
Okay, let's move to Module 2. The biochemical balance. Kidneys and hormones. This feels a bit more abstract.
It is abstract, but the stakes are incredibly high. Your body is basically a battery. It runs on electrolytes. If the balance is off, the machine stops.
Case 10 in the renal section is a perfect example. A suicide attempt. Someone swallows a whole bottle of potassium tablet.
Hyperkalemia, a true medical emergency. Potassium regulates the electrical reset of your heart cells. Too much, and the heart can't reset.
It just stopped.
It just stops.
So how do you spot it?
On the ECG, you see these peak T waves. They look like sharp, tall mountains. That's the heart screaming that it's electrically unstable.
So if the potassium is the poison, I assume we need to get it out. Dialysis.
Eventually, yes. But dialysis takes time. You don't have that time. The book highlights a critical first step.
What is it?
You give calcium gluconate first.
And that lowers the potassium.
No, that's the brilliant trick. It doesn't change the potassium level at all.
So what does it do?
It acts like a force field for the heart muscle. It stabilizes the membrane so the heart keeps beating while you work on getting the potassium out. It buys you 30 minutes of life.
That is a crucial distinction. Okay, moving to hormones. Endocrinology case 9 gives us a rhyme that I think every med student memorizes.
Ah, yes, for hyperparathyroidism. Painful bones, renal stones, abdominal groans, and psychiatric overtones.
It's catchy, but let's break it down. Why are the bones painful?
So the parathyroid glands control calcium. If they're in overdrive, they start stealing calcium from your bones to put it into your blood.
Which makes the bones weak.
Weak and prone to fractures. Painful bones.
And renal stones, I assume that's the calcium.
All that extra calcium has to go somewhere. The kidneys try to filter it, and it crystallizes into kidney stones.
Abdominal groans.
High calcium slows down the gut, constipation, ulcers, hence the groans.
And finally, psychiatric overtones.
Confusion, depression, lethargy. High calcium messes with your brain, so if you see a patient who is confused and constipated with kidney stones...
check their neck for a parathyroid tumor.
Exactly.
Let's talk about the big one in endo. Diabetes. The book zooms in on the complications.
Right. For type 1 diabetics, the nightmare is DKA, diabetic ketoacidosis. The body has no insulin, so it can't use sugar for fuel. It starts burning fat instead.
Which produces acid.
Ketones. And the patient tries to breathe that acid out. You'll see small respirations, these deep, rapid, heaving breaths.
And their breath might smell fruity.
Like nail polish remover. That's the smell of the ketones.
One last hormone case. The tumor that causes spells.
Pheochromocytoma, a rare adrenal gland tumor that just dumps adrenaline into the bloodstream.
An adrenaline overdose.
It is. The book uses the 5PS to spot it. pressure, sky-high blood pressure, pain, severe headaches, perspiration, drenching sweat, palpitations, heart racing, and pallor, they go pale.
Ow.
It comes in waves.
Yeah.
If you miss it, that blood pressure spike can cause a stroke.
Okay, Module 3, the visual diagnosis, dermatology, and infectious disease. The skin is a billboard for what's happening inside.
Absolutely. A rash is rarely just a rash. Take derm case 1, acanthosis nigricans.
This is the dark, velvet-like skin, usually in the armpits or on the neck. It almost looks like dirt.
It does, but you can't scrub it off. And the book warns us, this is a marker for insulin resistance. It's telling you the patient is pre-diabetic or diabetic.
So you see the skin.
But you treat the pancreas.
Then there are the blistering diseases. Pemphigus versus bullous pemphigoid. I always get these mixed up.
The book gives a very tactile way to tell them apart. Pemphigus has flaccid, weak blisters, and there's the Nikolsky sign.
That's the rubbing test.
Yes. If you rub the patient's normal-looking skin next to a blister, the top layer just slides off.
No.
That's a positive Nikolsky sign, and it's very dangerous. It means the glue holding the skin together is gone.
Versus bullous pemphigoid.
Those are tense blisters. They're tough. They don't break easily, and the Nikolsky sign is negative.
Let's talk bugs. Infectious disease. Meningitis is a huge one.
Neurocase 13 covers it. Infection of the fluid around the brain. You look for the classic triad: fever, stiff neck, and altered mental status.
And there's a physical maneuver.
Brzezinski's sign. It's fascinating. If the patient is lying flat and you lift their head up, their hips and knees will involuntarily curl up.
Why does that happen?
The lining of the spinal cord is so inflamed that stretching it hurts. Curling the legs relieves that tension. It's a reflex.
Module 4, vulnerable populations. PEDS and obstetrics. This section gets pretty heavy.
It does. Pediatrics case 1 covers child abuse. It's somber, but as a physician, you are the safety net. The vignette is an 8-month-old who is too sleepy with a rib fracture.
And a subdural hematoma, a brain bleed.
Right. Shaken baby syndrome. The book emphasizes that if you see this, you have a mandatory duty to report. You don't need to prove it, you just need suspicion.
And you look for other injuries.
Yes, you order a skeletal survey, you x-ray every bone in the body to look for old healing fractures. It builds the case to protect that child.
Switching to obstetrics, ectopic pregnancy case 5.
This is rule number 1. Any woman of childbearing age with abdominal pain has an ectopic pregnancy until proven otherwise.
That seems extreme.
It has to be. An ectopic pregnancy is when the egg implants in the fallopian tube. As it grows, it will burst the tube.
And the bleeding is internal.
Massive and internal. So you always run a pregnancy test. A beta HCG first. Always.
And what about late pregnancy? Case 21 covers preeclampsia.
High blood pressure and protein in the urine after 20 wints. If that pressure causes seizures, it becomes eclampsia. The only cure is delivery. Get the baby out.
Speaking of delivery, case 22 describes a nightmare. Shoulder dystocia. The head is out, but the baby is stuck.
This is pure adrenaline. The baby is trapped behind the mother's pubic bone. You have seconds before the baby loses oxygen.
And the book teaches a specific move.
The McRoberts maneuver. You flex the mother's hips way back, knees to ears. It just tilts the pelvis enough to free the shoulder. Simple geometry that saves lives.
Okay, home stretch. Module 5. The hidden systems. Neurology, psychiatry, and trauma.
Let's start with neurology case 17. Stroke. The biggest decision is binary. Is it a clog or a bleed?
Ischemic or hemorrhagic, and you can't tell just by looking.
No. They look the same on the outside. Slurred speech, one side paralyzed. You need a CT scan immediately.
Why?
Because the treatment for a clog is TPA, a powerful clot buster. But if you give a clot buster to someone who is bleeding into their brain...
You turn a bad situation into a fatal one.
Exactly. Rule out the bleed first.
What about seizures? Case 12, a febrile seizure in a child.
This reassures a lot of parents. A simple febrile seizure happens in little kids just because their fever spiked too fast. If it's short and they wake up fine, it's usually benign.
You don't put them on heavy seizure meds for life.
No, you just manage the fever.
Moving to psych, the book contrasts two students. One is taking pills to stay awake.
Amphetamine intoxication. Case 1. Agitated, huge pupils, heart racing.
Versus case 6, the student with an eating disorder, bulimia.
The clues there are physical. You look for enamel erosion on the teeth from stomach acid, and scars on the knuckles rustle sign from inducing gagging.
Physical evidence of a behavioral struggle.
Precisely.
And finally, trauma. The book hammers home the primary survey.
The ABCDEs. Airway, breathing, circulation, disability, exposure. It's a disciplined approach to chaos. You never move to B until A is fixed.
And there is a specific warning in trauma case 21. a motorcycle crash patient.
Ah, yes, the pelvic fracture.
The book says to look at the meatus, the opening of the penis, if
Yeah.
there is blood there.
Stop. Do not insert a catheter.
Why? I thought checking urine output was standard.
It is, usually. But blood at the meatus suggests the urethra, the tube carrying urine, has been torn. If you try to jam a Foley catheter up there, you can turn a partial tear into a complete transection.
You literally rip the plumbing apart.
It's a career-saving tip. You need to call urology for a special x-ray before you touch it.
So we've covered hearts, hormones, skin, babies, brains, and trauma. What does this all add up to?
If we connect this all together, medicine is about pattern recognition. This book isn't just a list of diseases, it's a training manual for your intuition.
It builds a mental library.
Exactly. When you see tearing chest pain, your brain instantly goes to dissection. You see blood at the meatus, you think, stop, no catheter.
It turns the infinite complexity of the body into solvable puzzles.
And it allows you to act fast when fast is the only thing that matters.
Before we wrap up, let's do a quick review exercise, a little quiz for our listener.
Go for it.
Okay, here's the scenario. A patient walks in, they're complaining of vague stomach pain, and they are super constipated. Your family says they've been acting confused, almost depressed, and their chart shows they passed a kidney stone 2 months ago. Labs show their calcium is sky high. What's the diagnosis?
Okay, let's analyze the pattern. You have the abdominal groans with the constipation. You have the psychiatric overtones with the confusion. You have the renal stones history. And the high calcium confirms the whole mechanism.
It fits the rhyme.
It fits the rhyme perfectly. Bones, stones, groans, and psychiatric overtones.
So the diagnosis is?
The diagnosis is primary hyperparathyroidism. You need to find that tumor on the parathyroid gland.
We nailed it.
One final thought before we go. The book includes a disclaimer that medicine is an ever-changing science. What we talked about today, protocols, drug dosages, it evolves.
Lifelong learning.
It's the core of this profession. Always verify and always stay curious.
Couldn't have said it better myself. To all the learners out there, go tackle your next case. Thanks for listening to The Deep Dive.
Goodbye, everyone.